Yes, hi everybody. Welcome back to this clinician interview series that we've got going on here on the channel. I'm delighted to be joined today by Dr. Phill Molloy, who is an anaesthetics trainee doctor currently working on the front line in the COVID-ridden hospitals of Great Britain. Phil, thank you for joining us today.
It's a pleasure. Thank you for having me.
Fantastic. So Phil, could you just give us a quick rundown of who you are and what you do?
Yeah, so my name's Phil. I'm one of the anaesthetic trainees. I'm currently based in the emergency department on the front line, dealing with all our lovely COVID patients. That's basically in a nutshell.
Perfect. Just let's very briefly then run through medical school, your kind of foundation job. So whereabouts did you train?
So I trained up in Keele. So initially I'm a postgraduate student as well. Initially I did a undergraduate at Manchester, and then I went to do the 5-year course at Keele.
Great. What did you study beforehand, your undergrad?
So I've a bit of a strange degree. I have a bachelor's of genetics,
Right.
which initially I wanted to be a clinical geneticist, and I was told the only way to do that was to undertake a degree in medicine. Having gone through med school, I was fortunate enough to get onto an academic foundation program where I did leadership and management a couple of years in the East Midlands. And from there, I've somehow ended up in anaesthesia.
Well, we can talk a little bit about that. So I think this is the first time that the academic foundation program has come up in one of these interviews. So for the boys and girls at home, who I think are aware of what the foundation program is, do you mind just running us through what the AFP is?
Sure. So majority of people just do a normal foundation program where they go through 3 rotations each year involving either medicine or specialties or surgery for a couple of years. The academic foundation program offers it's probably about 1,000 people a year to go into either research, leadership and management, or medical education. When I applied a couple of years ago, there were only 24 posts for leadership and management, and I hope by the time you guys get there, there'll be a lot more, as there's a big drive to get more clinicians into leadership roles. And essentially all it is during your 3 years, you get time off to do either some leadership and management activities, some educational activities, or some research. So that might be 4-month block completely blocked out just to do research. In my case, it was actually 2 days off a week for an entire year, and wow. The bonus was I didn't do nights, weekends, or any on calls. So it was a bit of a win-win, no-brainer for me to enjoy my year doing some quite interesting projects.
Wow. Obviously, that's you said there's only 1,000 places a year. It's a competitive process. How did you find that side of it?
Yeah, I kind of fell into it. Like my entire journey here now is I've sort of fallen just randomly into slots, really. So the first thing is, if you probably do need reasonable grades at medical school. I wouldn't kill yourself. You don't need to be top 10% or anything, but you need to be aiming for top 10%, top 50% of the year if you can. There are people who get in which aren't, and then we can talk. That's another story to talk about. The other thing is to do lots of extracurricular activities, such as doing research or medical education, or some leadership enterprises. Your med school will then often give you a sort of trial interview, just to see how you cope and whether or not they think it's worth you applying for it. And then under normal foundation rules, you don't require an interview. You just get graded 1 to sort of 6,000 in the UK. But for the AFPs, you need to get an interview. So you have to fill out an application process. And again, the medical schools will walk you through that. And then you get invited to interview. You have your interview. All interviews are very, very different. So I can't really comment on exactly what the medical education or research ones are. And then from that, you might be offered a place within a deanery. The other great thing about it is the situation and judgment test. Whilst on a normal foundation program that makes up probably half of your grade, it's actually, as long as you pass it, it doesn't actually make it count towards your application for an academic foundation program. So if you're worried about that, it's always good to give the academic foundation program a go if your grades are good and you've got a good CV.
Fantastic. Okay, cool. So then done the AFP, you've done your foundation jobs. So then from your background in clinical genetics and kind of always wanting to do that, how do you end up wanting to become an anaesthetist?
Yeah, so it's a strange one, isn't it? I went back to Manchester to work in the genetics department, and I realised that it was quite non-clinical. I think when I was an undergraduate, I saw the clinical things they did as sort of quite impressive, but really in medicine and surgery, you have a huge array of specialties offered to you. And as you go through medical school, you'll get gentle exposure to each of them. And actually, anaesthetics to me offered me more sort of excitement and enjoyment. So, and there are genetic components of it as well that you need to understand. So for me, it sort of focuses on the fundamentals of physiology, pharmacology, and pharmacokinetics. And it's quite practical as well. So as long as the academic side of things, you're always doing things practically, whether you're blocking nerves or intubating people, or the higher end of ITU, doing things like bronchoscopy and things. So it's more a well-rounded job rather than just being based in a lab like a geneticist quite often is.
Do you think, I mean, the reputation, certainly, I know anaesthetists probably the smartest doctors in the hospital. Is that a fair comment?
I can see why people might say that. The exams are very, very hard. I wouldn't say they're the smartest, but their exams are probably notoriously up there with the hardest exams for any postgraduate entry, really. So that's one thing to be aware of. I don't have any A-levels in chemistry or physics, and I'm starting to learn all the sort of basics before I go into exams, and it does get quite complicated. So if you're thinking about doing medicine and you're thinking about anesthesiology, picking chemistry and physics might help you in the long run in terms of getting in. But I know plenty of people who haven't and they've got through, and I know plenty of not so bright anaesthetists as well. So it's not really one rule for all, really.
Well, we just started to talk as well before we actually commenced this interview about the kind of the foggy path of anaesthetic training, because there seems to be a million and one ways in which you can go about it. So do you mind just running us through briefly how that works?
Sure. So there's kind of two ways to look at it. You can either do core anaesthetics, which is now 3 years as a core trainee and then 4 years as a registrar. Or you can do ACCS anaesthetics, which is a year longer in the core training. So it's 4 years now. And basically what that means is that the first 2 years you do 6 months in emergency medicine, 6 months in acute medicine, 6 months in ITU, and 6 months in anaesthetics before going back into anaesthetics to complete 2 more years. The core anaesthetics, you just do 3 years of anaesthetics with a 3-month block of ITU. So it's not quite as well-rounding, but you tend to be more focused on the anaesthetics. And the reasons why ACCS anaesthetics is possibly beneficial for people is they get to experience emergency medicine, acute medicine, and ITU more than the anaesthetic trainees, and you can actually swap into those specialties if you decide you want to. Or you can dual accredit, so you can become anaesthetists with 50% and 50% working in ITU, or 50% anaesthetists and 50% working in the emergency department. So it kind of gives you a bit more broader training and a bit more broader exposure to each department at a more senior level, not just at a junior F1 level.
Is that is ACCS? I mean, it seems based on what you've said that would be the more popular choice if it gives you that option.
I think they're both pretty much as competitive as each other. I don't have the figures. They haven't released the figures the last couple of years, to my knowledge. And more people are moving away from medicine and more interested in ACS training. So I think things will change. I think ACCS generally will become more and more competitive. And obviously you can do ACCS emergency medicine or ACCS acute medicine. So sure. You just do the same 4 things to begin with, and then you just do your parent specialty in the last year.
So there will be plenty of colleagues, say, who are also doing these ACCS rotations who don't intend to become anaesthetists. They'll become
absolutely
EM
yeah
docs.
absolutely, because the emergency doctors still need to control airways in acute emergencies. So lots of our emergency doctors working in the emergency department, this particularly senior ones, are able to intubate people. If push comes to shove, they don't always need the anaesthetist to come down and help to intubate unless it's an incredibly complex airway.
Amazing. So that's going to bring us next then, and the reason I guess why we began communicating at all, which is this book that I have here. So this is How to Draw Anatomy by Dr. Phill Molloy. Now, how just again for those at home, what is this book about? How did it come about? Did you always want to be an author? So on.
No. Basically, I'm not very good at anatomy, and I'm also not very good at drawing, and I also have dyslexia, which for me is an advantage because it makes me think differently to people, but it also, the disadvantages are I can't really spell, and I rely heavily on visual learning. And when I was a student, there were no real visual aids that allowed me to recreate my own notes. It was quite often complex pictures and books like Gray's Anatomy or Netters.
Sure.
So what I decided to do was to make my own drawings in a scrapbook. And I drew things out quite simply, but as anatomically correct as possible.
Yeah.
And a few of my peers saw my drawings in problem-based learning tutorials and asked where I got them from, and I just said I've just made them. So I knew there was some interest from my peers who thought it was a good idea, and I sort of took it from there. Really, I had a meeting with Elsevier, who published Gray's Anatomy, and they were quite interested. But through no fault of either our sort of no fault of them or myself, we decided to go our separate ways, and I eventually self-published it about a year ago.
Amazing. I mean, just again for reference, I've got here, this is going to obscure me completely, but hopefully you can see something like the gallbladder and the biliary tree. My webcam comes back into focus. What I really like about this is that I think for medical students, the problem with things like Gray's Anatomy and Netters, things like that, they are they almost describe what I would call the surgical anatomy rather than what you actually need to know to pass your exams.
Yeah, I would agree. This book basically got me through my anatomy. I mean, it doesn't have everything in it, and it's not going to be your Bible, but it contains about 80% of what you need to know, and gets the core fundamentals and basics. If you can learn what's in the book and replicate it, it's quite easy. And what I found through drawing is I could quickly draw things out or see them. So if they're saying what lies inferior to this, you can roughly work out what does lie inferior to certain structures and things like that. So
definitely. Yeah. I mean, it's just something that I don't feel people appreciate too much before they come to medical school, which is to pass the medical school exams. You're often, it's not learning what's kind of you need to learn the clinically important stuff, and without actually being able to fully photographically reproduce all the structures of the brainstem and so on. You just need to know roughly what is where. And I like the fact in here as well, just scanning through, there's the hot tips stuff for OSCEs and anatomy spotter exams and things like that. So it's really, if anyone's an early medical student, particularly thinking about their anatomy education, or a pre-medical student looking for a gift book for maybe someone to buy them, I certainly, if I was back in my pre-clinical year, early as a medical school, I'd have jumped on something like this. And really, I didn't come across a product like this. So really, really highly recommend this book to anyone listening at home. So Now we've done your journey through medical school. You're a practicing doctor. You've published a book, very good book. Let's talk about COVID.
Yeah, sure.
So you are working in the emergency department, you said,
Yeah.
at the moment. When all of this first hit, let's just take it back to, I don't know, the end of January, beginning of February, getting into February, when all of this started to pile up. What happened? How right at the beginning of all of this, how did it affect you, what you were doing as a doctor?
Sure. I was fortunate to work for a trust who were very hot on getting things right from day one. So the first thing I noticed is every day we had a half an hour discussion about COVID, updates from Italy, France, Spain, America, and other places around the world.
Sure.
And the first thing we decided to do once there was confirmed cases in London was to convert our majors department into a COVID hot zone. So that meant that anyone with shortness of breath, cough, or decreased sats had to be assessed in there if they were high risk for having COVID. Now, things have changed very much. The whole of our resus, the majority of our ED department is COVID. And our ambulatory care has been moved out into our trauma clinic, and our trauma clinic has been sent out of our hospital to another hospital. So really, it's completely changed the structure of the department. And the other thing is obviously personal protective equipment. When you're working in a hot zone, you have to wear full PPE. And what we mean by that is goggles for the eyes, a special mask that seals around and doesn't let any air into it and has a filter on it. You have to wear a hairnet, a full surgical gown and gloves, and a plastic apron over the top. And that's incredibly hard actually to work in. I didn't realize how hard that was to work in until I really had to do it, particularly with the weather that we've had recently. It's very tough. So doing more than 2 hours, you really, really do feel it. And a lot of our nursing staff are doing at least 6 hours there at a time. And I really take my hats off to them because they're doing a cracking job, really.
So being a doctor then on shop floor with COVID, so obviously PPE practices are having to be changed. We're separating hospitals into hot zones and cold zones and potentially contaminated areas and things. Has it changed what you yourself are doing day to day?
Yes. So simple things like our training has kind of been thrown out the window, so we don't have to necessarily do our usual competencies. So throughout being a doctor, from the lowest level to the top level, you have to get certain things signed off, and there's quite an extensive list for ACS trainings that's been put on hold.
What sort of things for you might they be?
So they might be things like dealing with anaphylaxis and having discussions with senior clinicians afterwards, or them assessing me on managing a trauma case on my own. They could be things like putting a chest drain in, or putting in an anesthetic drain. So that's a drain that goes into the tummy for people who have lots of fluid in their tummy. Basically, we're not really doing non-urgent things, and if people need chest drains in, quite often it's done by the most senior person available to begin with, whilst we have the resources, because they're quite high risk of spreading this nasty virus around. So that's the sort of flip side. But we are seeing lots. We're all managing them. At least I usually see at least 3 or 4 a day. Confirmed COVID cases, ranging from mild symptoms to those who have SATs below 50% and need immediate intubation.
So I've got some questions then, because we're all hearing different things, and the media says one thing, the government says another thing, doctors' unions say another thing, and the public are off somewhere else saying another thing. Just some quick fire questions. Your frontline on shop floor, best place to tell us what's actually going on in hospitals. Do trusts in general, obviously you can only speak for yours, do we have adequate PPE?
My trust has adequate PPE. We are all very aware of the fact that it will eventually run out. So I'm assured by my seniors that they'll keep ordering in stocks. The main thing is whether the government are ordering enough for our trust then to get it back. But currently, my trust certainly has enough PPE, but I know there are other trusts around the country which don't. Who I feel sorry for the most are people who work in care homes in the care sector, and those working in shops and things. It's tricky. We're not going to have enough for everyone, and the government has a hard job. But in an ideal world, everyone would be wearing proper PPE who was out and about.
Sure. As you say, maybe an ideal rather than the reality. In which we live. Okay, I've also heard, again, haven't managed to confirm this is true or false, that certain anaesthetic guidelines, such as obviously the SATS guidelines for when you would choose to intubate someone or the best position to have them in and so on, that COVID patients behave somewhat differently than what we would expect sometimes.
Yeah, they do. The guidelines are changing almost daily, depending on the evidence and research conducted both in the UK and around the world. It might have changed since I was last in, but essentially those who are not managing to maintain their stats above 90% with 100% oxygen essentially are the ones we usually decide to intubate. However, if they have extensive comorbidities and they're unlikely to survive an ITU admission, we need to have that discussion because it's not always in the patient's best interests as well. It's tricky at the moment. We have full capacity for ITU in the UK. Generally is coping quite well. The main worry would be if we start to see 3-4 times the numbers of patients, similar to how Italy were, and in that case, we would really start to struggle to intubate everyone just because we'd have nowhere to put them or look after them or not on a ventilator. So that's why this social isolation and flattening the curve is so important, so that the NHS can cope and make sure everyone who deserves to be intubated can get a ventilator and give them the very best chance of surviving the disease.
I feel like, again, for the benefit of those at home listening, we're throwing the term around. What exactly do you mean by intubation?
Sure. Sorry, I should have mentioned that earlier to everyone listening. Essentially, when we take over your breathing, so for that we need to give you a general anaesthetic and paralyze your muscles and put a small tube into the throat so that we can take over the action of the lungs. And this is because in your lungs, with COVID, the lungs get full of fluid, and there's lots of complex physiology I won't bore you with, but essentially they collapse down as well. So they're full of fluid and they collapse down. So they're like sponges that have been squashed, but full of water. And what we want to do is put the tube in and blow the lungs up. So we push all the water out of the lungs and expand them properly and make sure your oxygenation levels are normal. If your oxygen levels are abnormal, it can affect the brain and long term can cause problems with the brain's cognition and ultimately lead to sort of a not good picture after a while. So intubation is just a tube down the throat. Essentially, is what you see on Casualty.
Good. It just occurred to me that it's kind of everyday parlance, I suppose, in hospitals, isn't it? But actually, it's
sure.
It's as you say on Casualty and Holby City and all that. It's never I've kind of dwelled on, and that actually kind of brings us nicely onto the last bulky thing that I want to talk about today, which is testing. And you yourself are a COVID positive patient.
I am, yeah. I'm a COVID survivor. I was one of there was a small outbreak within our department. We're about sort of 15 of our staff now have had COVID. We're all young, fit and healthy individuals. To my knowledge, everyone has done pretty well so far. For me, it started off with headaches, temperatures, muscle aches, which we call myalgia. You might hear people talk about myalgia. That's muscle aches, posh Latin word for that. And a bit of shortness of breath and chest tightness. it lasted for me for 2 weeks, which is a lot longer than I
Wow.
thought it would.
Yeah.
Lots of people get mild symptoms. Some people get no symptoms, and some people get worse symptoms than me. Typically around day 7 to 10, people can become a bit iller, and if they require hospital admission, around that time they might require admission for some oxygen, just to help support the lungs. But fortunately, I'm a COVID survivor. I'm now just over 3 weeks ago I had it, and I'm pretty much back to normal now.
Is there a protocol on when, assuming you wish to return to work, that you might be able to?
Yeah, I think each trust might have slightly different protocols. Again, I work with a really, really good trust, and they've been pretty crystal clear. They communicate within our staff workforce, our small unit and ED, via WhatsApp daily, and then obviously have the email updates from the main trust. But for us, it was, first of all, 7 days off, and then you had to be 2 days symptomatic free. So if you're still having temperatures, fevers, muscle aches, or shortness of breath, until that had all settled down, you weren't allowed to go back, and you had to have an additional 2 days off as well.
Cool. So testing protocol at the moment, this is obviously one of the huge areas of concern, that different countries are doing different things, and everyone wants to know, when can we be tested? How can we be tested? What was that procedure like for you?
So yeah, I got it just over 3 weeks ago. So testing was still quite cumbersome. Initially, there wasn't a lot of testing for staff, but I was fortunate to be one of the first staff members tested. Usually what they ask you to do is drive to a car park somewhere, and they have a sort of makeshift testing facility, and they swab the back of your throat and off in your nose as well. They take your details, and then they'll give you a call back as soon as they get the results to tell you whether it's positive or negative.
How long?
For me, for me, interestingly, that only took a day. I was told up to 4 days, but I got it back in a day. There is going to be at my trust soon some testing using this antibody test that everyone's been talking about. And it's more the early phases of it. It won't be offered necessarily. It won't be 100% diagnostic, but it will be where they take a small blood sample from the finger, and they can work out if you have certain antibodies in your blood from the infection, to show whether you are infective or whether you've had it and now you've got immunity to it.
Are you able to very briefly, again, this is for the boys and girls at home, just the difference between the antigen and the antibody test and what they each might mean?
Sure. So the antigen would be a small part of the virus in your bloodstream that we can detect. And the antibody is produced by your blood cells once you've had an infection and overcome it, so that when you next come in contact with that antigen, so a bit of the virus, the antibodies bind to it all, mop it all up and destroy it all, so it can't replicate in your cells and lead to a disease. So
the antigen, if I understand correctly based on what you've just said, and hoping this is correct, if I have the virus, if I'm currently infected, I will be positive on an antigen test.
Sure.
In theory, but if
what we tend to do, I think, is PCR. So again, that's probably another discussion. It's a genetic test where we're able to work out if you have a sequence of letters that belong to that virus. That's why we do the swab tests initially. The antibody test will prove those who are immune. So in the long run, for the government's grand plan, anyone who's immune should theoretically go back to work and can work, because they are not able to shed the virus. They're able to spread it still. If someone coughs on them and they have it on their jumper, for example, and they touch it and touch another surface, they can still spread it that way, but they're not actively making more and more virus and spreading it around that way. So I think the government's exit plan is to get this antibody test up to speed, so they can determine who is immune to the virus and therefore can go back to work with less risk of spreading.
I was going to say that this presumably is based on what is not an unreasonable assumption, that you can't be infected multiple times with COVID-19.
Yeah, that's the current theory. I think there was one case that I was aware of where they had it twice, but it was dubious and they weren't sure if they actually did have it twice. But theoretically, if you've had an infection from a virus, you gain immunity and you survive. You shouldn't be able to be reinfected with that virus in a short time period. Over many years, you can lose that immunity, but theoretically, you should have some short-lived immunity to it.
And the last question that I have for you, Phil, is I feel like most of us, I will, as of next week, thankfully or unthankfully, we're all wanting to know, what's the feeling like inside hospitals? How are the NHS, how are the workforce coping? People are banding together and we're seeing the public support for the NHS and all this and that. What's it actually like on the inside?
Sure. The first thing is the public support has been amazing. I've never known the public to sort of be so receptive and grateful for the NHS. And I think the NHS is very grateful that the public are doing a really good job staying indoors, not going out as often, as they want to, and really protecting the NHS. The other thing is the generosity that we've seen from businesses to individuals, businesses donating food, particularly for the first 4 weeks of the virus. No one in our department could get pasta. Just basic things we were unable to get, toilet rolls and stuff, and kindly some business donated meals or some pasta for the department. The morale is the highest I've ever known it.
Wow.
And I think in short, this is because when there's a crisis, people generally come together. We have neurosurgeons, so surgeons who specialise in operating on the brain. The middle grades, so the doctors that have been only doing that for 3 or 4 years, have been released, and they have joined the front line, either in medicine or ED, and they're working with us at a much junior role. So we get to boss them around, which is great. Again, they've taken that on really, really well. They know that they haven't done that job for a long, long time, or they've done it a few, sort of 5, 6, 7 years ago. They've been very enthusiastic and willing to help and learn from the more junior guys who are technically more senior, which is quite interesting.
Strange finding. Okay, well, absolutely. Phil, thank you so much for coming to speak to me today. I'm sure everyone will find this really, really interesting.
Sure.
How can people keep up with your projects and endeavours?
The book one.
Sure, if that's what you'd prefer.
I have an Instagram channel called How to Draw Anatomy. It's all one words. You can drop me a message on there. That's the book there. You don't have to buy the book. I do lots of videos of the drawings from the book anyway. I'm not really here to make money off the book. It's more just if people want it. I'm quite keen to get it to as many people as possible who need it. Drop me a message. And if there's a university that's interested, again, I can pretty much do them for cost price for the library and things as well. So if people are interested in getting the book, contact me there. If they're interested about anaesthetics or medicine in general, they can also drop me a message on the How to Draw Anatomy. One of my colleagues helps me run the page, and it's probably I check it most days. So feel free to drop me a message.
Fantastic. I'll make sure that links to the Instagram page they'll be in the comment section and in the description for this video as it goes live. How to Draw Anatomy, so that will all be attached to the video. Any parting words, Phil?
I hope everyone stays safe. This pandemic will end. It might be many, many weeks and months before we overcome it completely. But I wish everyone the best, and I hope they keep their loved ones safe.
Fantastic. Well, thanks so much, Phil. Hopefully we'll catch you up again soon.
Sure.
Take care.
Thanks, Ollie. Take care now. Bye-bye.